Welcome, all of you fantastic dental podcast listeners, to the My Practice, My Business Dental Podcast Show, where we help dentists profit and thrive with excerpts from the clinical business of dentistry training here at My Practice, My Business. We'll be addressing and answering questions with current trends dentists and their teams face each and every day in their pursuit of this wonderful career we call dentistry. And now, the host of our show, the clinical director and president at My Practice, My Business, Dr. Rob Thorup.
Welcome to the My Practice, My Business podcast and YouTube channel. Hey, I'm really excited about today because this is a topic I've been trying to get my wonderful hygienist to come do with me. We've all been so busy, and today we had to shoot some video for Thorup Dental, but now we're on to My Practice, My Business and our podcast, and I am so pumped about this topic. And the topic today is dentistry's blind eye to gingival infection. I said it. Are we in trouble now? Okay, this is going to be really fun. This is a podcast and a video that you're going to want to watch all the way to the end because we're going to cover some things that are going to be pretty powerful. And, you know, every dentist would like to say, oh, my hygienist team, they're the best. I got the best hygienist. I'm sorry, docs, I do. And I want to introduce them. My hygienists been working with me for some of them for many years, some of them for a year or so or three. Yeah. So I'm going to start out with Courtney here. Courtney, go ahead and introduce yourself to the people that are watching and listening.
Okay, my name is Courtney. I've been a hygienist now for 10 years this May, and I have kind of an interesting background in dental hygiene. I went to school in Pennsylvania. I'm from Pittsburgh, Pennsylvania, and I practiced in Pennsylvania for a couple of years. My husband was in the military, so we moved down to North Carolina. So I practiced in North Carolina for a few years. And then we moved here 4 years ago to Utah, and I got to do some temping work around the Valley area, and that was very interesting, to say the least. But that's how I got to meet Dr. Rob Thorup, and it's really changed my hygiene career, and I've been with him since and just loving every minute of it. So,
and we changed it for the worse?
No, absolutely not. For the better, just higher standards and more in line with how I'd like to practice. So
it's pretty fun. When I talked with you many years ago, I just knew right off the bat that our thought leadership aligned.
Absolutely.
That's really exciting. Thank you. Yeah. Nichelle, you get to introduce yourself.
Hi.
Nichelle, she's been with me for many years.
Yeah, 12 years.
We recruited her right out of school.
Weeks. Yeah. My name's Nichelle, and I've been here 12 years. I got really lucky somehow, and right out of school, I saw a KSL ad for a job that might give away my age a little bit, but KSL ad for a job here at Thorup Dental. I came and I got it, and I quickly decided that I would never leave. I've temped around at a few enough offices that I know that I just want to be here. So.
I didn't pay her to say that either. I just want everybody to know. It was fun when we looked at Nichelle's curriculum vitae and we said, oh my gosh, we definitely want this hygienist here. She was one of those super smarty pants in high school. So she graduated top of your class, something like that. Whatever. Okay, but that was a good reason to keep her, and it was a great decision we did. So I made 2 great decisions. Laura, go ahead and introduce yourself.
All right, I'm Laura. I am the oldest hygienist here. I've been practicing for 18 years in dentistry since 2002. So
that was so
assistant,
old.
I know.
Ugh. It's nothing compared to Ron.
Not as old as me. Thanks, Michelle.
I've done a little bit. I've worked in an office for almost 10 years, left that office when our thought leadership was not aligning, and took a few years to try and find a new dental home where I fit, where they allowed me to practice at the height of my abilities. And I found Rob through a friend, and it's been great. I said, one of us will die, and that's how we'll end. Because I am not going anywhere. So if I have to move, I guess my husband moves without me. And if Rob has to move, I move with him, because this is the only way I can treat patients now.
Don't we wish all of our employees were like that? I mean, all 3 of them, I've fired them probably half a dozen times. They just keep coming back. I can't get rid of them. Yeah. Nor would I ever get rid of them. Well, this is going to be exciting because these are topics that we have talked about for years amongst each other. And I love my team because my team, they think outside the box. We train at My Practice, My Business. We train in periodontal therapy, gingivitis, or I'll say gingival therapy. And one of the things that I love about my team is they're always looking for ways to better serve our patients. What can we do to improve our patient's life? And also, what a concept to be paid fairly for that service that we provide. That's one of the biggest things that we work on at My Practice, My Business. We don't treat to insurance plan limitations, and yet we take over, 22 to 25 insurance plans. We are a PPO providing office, but we're profitable with all of our PPO plans. One of the mantras that we teach at My Practice, My Business, and it's knowing state laws and knowing insurance contracts that allow you to be profitable instead of the false misinformation that's being taught out there all the time. So yes, you can be profitable with PPO plans, can't we?
Absolutely.
That's absolutely. Well, today we're going to talk about dentistry's blind eye to gingival infection, and more specifically, how gingivitis and periodontal disease are systematically undertreated. They're mismanaged, in my opinion, too, and downplayed in dentistry. And I'm going to get into that a little bit. I can't wait to talk about that. And not because that we lack knowledge or tools, but because of culture, which you've all experienced, hierarchy, insurance-driven thinking, which is something that we blow apart at My Practice, My Business, but also outdated protocols. As we have discovered many new medications and techniques and technologies to actually eliminate gingivitis and to eliminate the nemesis of life, periodontal disease, or what we term periodontal infection, which is actually, in our opinion, a more correct name to call it, right? Okay. Well, in this episode is definitely for dentists and for sure hygienists, but this episode's also for the public, because what's happening in dental offices every day is actually not good for the public. And it's like I'm not calling you guys out on this. I am asking you to up your game because you know how. You have the skill set, the hygienists do. We docs, we sometimes hold them back. And it's important for you to know I'm guilty. Throughout many, many years of my practicing career, since 1989, we used to treat gingival inflammation with a prophy constantly. Click our heels together, hope everything gets better, yell at the patient to brush and floss more. Am I correct in all that? There's probably more, okay? And it's certainly not good for the professionals who actually want to do better. So I can't wait to get into this discussion. Our first topic, hygienists are not supported to treat infection. Oops, am I hitting the hard one right off the bat? So I want to start here. Hygienists are often not supported by dentists they work for. Docs, maybe this is the reason in Utah and other states that hygienists want autonomy, because we're not supporting them how we should to properly do what? Treat periodontal disease and gingivitis. And I want to be clear, it's not a skill set problem that you all have, is it? No, it's not a motivation problem, especially with hygienists that are paid a percentage of production or paid on all production, right? And it's not a permission problem either. There are hygienists all over the country who know their patients have infection, want to treat it properly, and could treat it properly, but are held back by the doctor employer who controls protocols, time, materials, and treatment philosophy. And that hierarchy matters and is hurting patients. Have any of you experienced that before? Go, Courtney, let her rip.
Oh, have I? Well,
here we go.
As I said before, temping in the Valley has been very interesting. Just working with several doctors at a time and, their philosophies, it just is like a whirlwind. But time and time again, I've had doctors just tell me, we don't have time for all this. Just clean them up and we'll see them back and just see how they look.
Even the doctors that we have in training, in the team training, advanced training, they admit that.
Yeah, absolutely.
And why do they do that, Court? Why do you think that?
Honestly, it doesn't make sense, because if you treat the patient to what they need, usually that's a little bit more of a production, right? So you would think they would want that extra production by treating the patient the way they need it.
Medicated mouth rinses, fluorides that actually have medication in them, antibiotics,
all kinds of things.
Direct.
Indirect.
Yeah.
The Yes.
Systemic.
Systemic, yes, sorry.
Oh, my bad. Exactly.
But yeah, you would think that these doctors would encourage us to go after the disease and treat it the way it needs to be. But time and time again, I've had people just tell me basically to ignore it. And I am flabbergasted every time.
Especially gingivitis, right?
Yeah, absolutely.
How many times have you had
undiagnosed.
patients, you got a crime scene on the bib
Absolutely.
and you slopped it on
All
their
the time.
white shirt? You ever done that? I've done that.
I try not to. It doesn't look
Exactly.
very good. But yeah, I mean, what do you think? Do you guys agree?
Michelle?
Yeah, I totally
Thoughts?
agree with that. There was one time I temped at an office and they gave me 15 minutes for periodontal maintenance.
15 whole minutes?
15 minutes
Whole
was
minutes.
the
That's
schedule.
like
That was the
14 minutes
schedule.
more
Yeah.
than you need just to read through the notes and figure out
know.
what happened to the
Yeah,
patient.
the assistant took x-rays, but that was like cleaning, polishing, flossing, like let alone any sort of like oral hygiene instructions didn't exist. And there was calculus everywhere. And
That's
so,
an office that just doesn't know what they don't know.
Yeah.
Would you agree with that?
Yeah, absolutely.
Yeah. But what else? Anything?
Yeah, I remember thinking like I'm just going to do the best I can. And I just let them go. And I thought like I didn't actually do that much.
How many?
But
how
go
many
pay
of
your copay and go home, I guess.
How many of our colleagues, hygienists, you're all my colleagues. I treat my hygienists like colleagues. And that's how we should be treating them. Don't even get me started there. We co-diagnose together, don't we? We're a team. I love that. But how many times it's like you just said something that actually blew my brain. I'm just going to do the best I can with the time I have.
Mm-hmm.
And it was not that good of a job, I will admit.
Thank you.
It can't be.
I was just going to say, I can't do a good job in 15 minutes. Yeah. Laura?
No, I've seen exactly the same things where the dentist maybe the patient complains to the dentist and says, well, she says I have this infection in my mouth. And the dentist's like, it's not a big deal. You're fine. It's not a big deal. And I'm like, but it is. It is a big deal. And I've also seen hygienists just become complacent as well because they're so used to being told no.
I was just going to say, they're used to being beat down.
Yeah. And so
Right.
that's their daily is I'll just do the best I can. And they forget how good of a job they can do. They forget how much oral hygiene instruction for patients is important. And so I think it takes.
Okay. I was just going to say, do you three get paid for oral hygiene instruction with some of the modalities that we do?
Yeah,
Yes,
we
we
do.
do.
I mean,
Yes,
so we
do.
actually
Time.
charge the patient for it?
Yeah, we do.
What a concept. No, let's treat to insurance plan limitations. What does it say on the EOB? Inclusive. This procedure is the patient is not to be charged for the procedure. What are all the stuff that it says?
Mm-hmm.
It's an actual D code in the CDT code book, right?
I was just about to say that.
So
why
doesn't
why
it-
have the
Yeah.
code?
Doesn't
Yep.
it fall under non-covered service laws? Okay, we won't even go there.
No,
All right.
we won't. We'll get too angry.
That's another topic.
Yeah, here's another one. Routine cleanings for diseased tissue, which is kind of what you guys were alluding to,
Yeah.
right?
Yeah.
Right. Patients come into a dental office every day for exams and cleanings, and many of these patients have visibly unhealthy gum tissue. Like the one we saw just the other day. Who was with me with the one that the patient we had? Oh, bless her heart.
I was thinking
I mean,
it could
she
be all
smiled,
of us.
and it is
Oh,
like,
yes, that was
you.
mine.
That's probably
yes.
Yeah, I'm like, whoa.
She hadn't been since she
And
was 16 and she's
I
23
can't-
years old.
I can't wait till you bring her back to full health. It's going to change her whole
Yes.
being, And I guarantee, which we see all the time, when we bring our patients back to full health, when you ladies bring our patients back to full health, the common statement is, I have more energy.
Yeah.
Isn't it? I've heard that so many times. The body's immune system's working overtime here, and it's not meant to do that.
Sometimes I feel like
So-
their complexion changes, literally. Like they look better when they come in. Yeah, I'm serious.
lively.
No, you're
people who have like really
absolutely
severe
correct.
periodontal
Yes,
disease, they
you
come
are.
in and you're like, you look different. You're smiling and you have like better
Yeah,
complexion.
their confidence
yeah.
comes
That
back.
gum tissue is red, swollen, bleeding on probing. Okay, 4 millimeter pockets or deeper. Okay, and then the only thing gingivitis doesn't have is radiographic bone destruction. So let's just still call it what it is: infection in the gum tissue, right?
Yeah.
Okay, and what happens? They receive scaling and polishing only, and then we click our heels together 3 times, follow the yellow brick road, and hope everything magically heals, right? So no infection-based diagnosis, no antibacterial therapy, no follow-up, just, I'm guilty. Years ago, I'm just going to say it. Look, just brush better and floss more, and this will all magically go away, right? Without even taking the time to show them how to brush and floss better. And isn't that our patients' main problem? They really, truly don't know how to brush and floss better. And then both hygienists and dentists are underdiagnosing and undertreating gingivitis, and that's a hard truth that we need to own as a profession. And I love it that in our office here, I give you ladies a full hour. You have a full hour uninterrupted, and sometimes if it's a patient that's got issue, if it's a patient, I'm gonna say it, if it's a patient that has tissue issue, okay, or they've got tissue issues, I love saying that
like
phrase.
it.
You guys have heard, you've heard me say that a million times, okay? If they have a problem, you go over that hour time, don't you? And we back you up, right? Isn't that cool? So tell me your thoughts about routine cleanings for diseased tissue. How often have you seen that temping other places?
It's a very common issue. Like you said, gingivitis generally is just severely underdiagnosed, and it's affecting the patient's health. You know, we're not giving the option for them to clean up things and care for their health. And
Hey, Courtney, I have gingivitis. What are you throwing at me? What are you going to do to me besides beat me up if I actually had it personally? But pretend I'm just a regular patient.
I'm going to clean you until there is nothing left. And then I'm going to send you home with medicated mouth rinse.
Yep.
I'm going to go over oral hygiene instruction like no one has ever done.
Yep.
I'm going to be that nagging wife or that mother, and I'm going to pull out the mirror and I'm going to be like, show me. And so that way we can be on the same page with home care, because home care is so important. And that really is a lot of the percentage of the healing.
Yeah.
And so I'm going to send you home. I'm going to bring you back in a couple weeks, and we're going to do
I was
another
waiting for
cleaning.
just to say it. I didn't, and this is so fun because this is off the cuff, folks. You're going to bring me back in 2 weeks. So you're going to use scaling in the presence of gingival inflammation.
Yeah, certainly
Michelle,
am.
does insurance cover scaling in the presence
No.
Not always.
But
So-
do we care?
No.
Exactly.
We don't care anymore.
No, we're going to charge the patient for it, aren't we? And do we ever treat to insurance perceived? Do we ever treat to perceived insurance plan limitations?
No.
Never.
It's
So-
based on what the
so-
patient needs.
So if they have gingivitis, you have all kinds of different things in your arsenal, don't you?
Yes.
Ladies, name some more. What else?
Minocycline, periodontal gel.
Minocycline periodontal gel in the infected tissue. What else?
We take a saliva sample. If it's really infected and involved, we want to know what bacteria we're dealing with, just like you would at the doctor.
Am I the one that tells you to do the saliva sample, or is that your wheelhouse?
It is our wheelhouse, which I love because we are seeing it the whole step of the way. We are probing. We are cleaning that, and we are seeing like how much bleeding, how advanced everything is. And so you just don't know that when you come in and do a 2-minute exam.
Yeah.
Might you put me on an antibiotic systemically?
Yeah, when the spit test comes back, it'll say an antibiotic to put you on. Systemic.
What about with gingivitis? What about if the spit test isn't going to come back because it's a holiday or something like that? Are you going to throw me on an antibiotic and then change it when it comes back? Change the antibiotic?
I don't know.
Yeah, I was going to say, we usually do that for the periodontal infection.
Yeah.
But for gingivitis, I'm a little bit more, it's just a little more superficial.
That
it's not
is
in
the
that
answer
deeper
I was
tissue.
hoping they'd say. They're a little more hesitant on the systemic, but you ready for this? I back them up. I always say to you, what do you want to do?
Mm-hmm.
And then we talk about it. Now, some of the times after I've examined the patient, do I change your course sometimes a little bit?
Yeah.
Mm-hmm.
Yeah.
But how often?
Not very.
Not very. And it's collaborative. It's
Yeah,
not like, oh, I'm going to tell you how to do this. You're like, you know what? I'm feeling this. What would you think about this? It's not undermining our expertise at all.
Right. Yeah.
How many dentists are afraid to have you place minocycline gel in the infected areas?
Yeah, a lot.
Yeah, I've been told not to order it from other offices. They're like, we don't do that here.
Okay, I just have one question. If you went into Instacare and you had infection in the gum tissue, what are they sending you home with? Among antibiotics. Moxicillin's their first drug of choice in the Instacares and the ERs.
Look at me raising my hand. But I always bring up, I've had kids, we had a bad summer where everyone got pink eye from the splash pad. It was so bad. But they sent us home with a systemic antibiotic and we had eye drops. We were fighting it from every direction to get rid of that infection.
Isn't that amazing?
And I've had that with ear infections too. We have eardrops and we have systemic antibiotics. And why is that such a hard concept for dentistry? So I tell my patients that, and then they make that connection. They're like, oh yeah, well, my doctor would do that. So yeah, I trust you because you're a healthcare facility.
Okay, so all of you think that we're all that in a bag of potato chips now and that we've been treating this like forever, treating gingival infection like this. Nichelle, when did we start treating gingival infection like this?
In 2016.
2016. So we haven't been treating it.
Yeah.
Gingival infection, periodontal infection, yes. Gingival infection, we were a little more hesitant. Gingival infection, gingivitis. How long ago did we start treating gingivitis more aggressively?
3 or 4 years ago, maybe?
That's right.
I was going to say it kind of was
So
when
docs, we haven't been treating it like that for very long. We just finally said to ourselves, I'm sick and tired of seeing infection. Why are we not treating gingivitis like the infection that it is? And how many spit tests did we send out? And the spit test came back with gingival infection as bad or almost as bad as periodontal infection.
Yeah.
Yep.
You'd be surprised.
So why don't we treat it like medical? Because we're afraid. And it costs more money.
Yeah.
Our typical gingival therapy for gingival infection ranges between, now they're going to test me. Okay, here we go. Somewhere between $600 and $1,500. Is that fair to say?
Yeah.
Okay. A lot more than a regular prophy and x-rays and an exam.
Yeah.
Well, how would medical treat it? Wouldn't they treat it like that? And it'd probably cost a lot more? Because it sounds like it does cost a lot more because you've all taken your kids in. Okay.
And you're not told beforehand what the cost is going to be.
Yeah,
you get surprise bills. And
Now,
it's just, we cater so much to the patient in
Get the
dentistry.
side bills.
Yeah.
You know, and what I think is important is I've started looking at every patient as how would I treat this infection if this was my husband, my mom, myself? What would I want to do? Because we accept so much bleeding in our patients because
you just caused a thought. How much bleeding would be permissible in all of our mouths?
Zero.
Then why do we allow our patients with gingival infection to take off and just prophy them and tell them have a good day? And I'll tell you why. Leads into the next one. Most hygienists were never taught how to treat gingivitis. Correct or incorrect? You tell me.
Yeah.
Correct.
That scaling with gingivitis didn't even exist.
I was going to say,
didn't even exist. That's probably why we started treating it so late here.
It's always scaling.
Yep.
Right.
Now, there are certain medications like chlorhexidine. We use that to attack gingivitis, don't we? It was never meant for a long-term use. And we just want to kill all the pathogens in there, nuke it all. And then once we bring them back to full health, by the way, when the patients come back in 2 weeks, what percentage of them are healthy again?
It depends on how good they've been doing with their oral hygiene stuff.
Nailed it.
So give me
really
a percentage.
I mean, I'd say most with our protocols and the way we treat things with the oral hygiene instructions, most are compliant because they spend a lot of money to invest in their treatment.
They put the fear of deity into the patient. I would be scared to death. I'd be brushing and flossing 10 times a day. If any one of these ladies told me, you're bad and you need...
I'd say about 90%.
90%. And so you bring them back in 2 weeks, 90+% of them are healthy again. What do you do with them if they're not healthy? Send them on their way? Beat them up? Bring them back again, right?
Yeah.
Okay. Are you scaling again?
Yeah.
Are you charging them an additional scaling in the presence of gingival inflammation code?
If they need it.
Because that's what we're doing.
Because that's what you're...
I was going to say,
exactly.
Bill for what you do.
Bill, oh my gosh.
Bill for
The
what you do.
ADA Code of Ethics, the statement in there is bill for what you do. Another statement that my sweet wife can quote is, it is up to the dentist to define how to satisfy the code. There you go. So why aren't we treating our patients like we would want to be treated? That's a major question, isn't it?
Yeah.
So most hygienists have no idea gingivitis can actually be treated as an infection. We treat it as an inflammatory process half the time or most of the time.
We ignore it until it turns into periodontal disease.
Yeah.
There you go.
Is really what we just watch it
I
march
was just
to
going to
death.
say that. That's what happens. Did you read
I'm
my notes
sorry.
on this?
She's
Okay.
taking
This
over.
is off the cuff. You could tell that.
So the next one is, if medical were treating an infection on the outside of the body, what would they do? They'd perform lab tests to identify the pathogens. They prescribe topical antimicrobials. They use systemic antibiotics if indicated, which most of the time it is. They instruct the patient to clean the infection daily. They schedule follow-up visits to ensure a resolution. What do we do in dentistry? The hygienist identifies bleeding, inflammation, infection, and is directed by their doctor or employer to scale and polish, tell the patient to brush and floss better, and hope it clears up. No antimicrobials. Do you ever see those when you're working for other people? No diagnostics, no follow-up, just hopium. Hopium is not a drug, and it's very rarely effective. Correct me
Another
if I'm-
dad joke.
I love that. I love
good.
it.
Yeah, it's one of my better dad jokes. Okay. Any comments on that? I mean, I know we've touched on it a little bit, but
I mean, I completely agree. I think our philosophy around Thorup Dental with all of our treatment is we're treating it exactly how medical would. They fight the infection until it's gone. We don't accept infection as a long-term solution to maintain. We're not supervising neglect. We are treating, the way we would want to be treating our family, because it's so important and it links to our overall health. It's not just about the mouth. So
not
we treat
anymore,
it-
is it? All the
Yeah.
research is showing us about
Exactly.
so many other things,
Yeah.
right?
Yeah. And if you had like a cut on your arm or leg or something,
Yeah.
and we can get that to heal up, you wouldn't just live with like an open wound on your arm the rest
Right.
of your life. Your mouth
Exactly.
is the same as
And
your arm.
Michelle, how does the wound clinic treat a wound? It's a
Yeah.
keratinized tissue issue. We don't have keratinized tissue in the mouth, so we have to treat it differently
Yeah.
every 6 weeks,
Mhm.
ideally. Okay, for those collagen fibers to reattach,
Yeah.
we have to be careful. They're juvenile. So when you ladies probe,
Good job.
we're just all guys here. When you ladies probe, you're gentle,
Yeah.
right?
Mhm.
We're not. That's how I would
Yeah.
probe, right?
Yeah.
Yeah.
Bring them back 6 weeks.
Okay.
No,
So
no earlier.
how often does medical see an infected wound on the outside of the body? My son that was in the Marine Corps, he came out. He's a wound and parabolic chamber tech for one of the local hospitals here in the state, and you've had some experience with that.
Yeah. Yeah. My husband got a precancerous mole removed. And they did stitches. It was on like the back of his knee. And the stitches never healed. The wound completely reopened, like an inch and a half probably.
Whoa.
He went back to the dermatologist, and the dermatologist basically told him to put a Band-Aid and Neosporin on it. And then it started getting green and started to stink.
Like periodontal disease does?
Yeah. Yeah. Uh-huh. Your breath smells.
Yeah.
His legs started to smell. So yeah, we sent him to the IHC wound clinic.
Yep.
And they were like, oh, we know what to do with this. And they would like curettage and scrape off the dead tissue. They gave him systemic antibiotics. They gave him like special silver infused gauze with antibiotic ointment on it. And they had him come in every.
Did they take a culture?
Yeah, they did.
Oh, what a concept.
Yeah. Yeah. And then base the antibiotics based on that.
Why don't we take cultures of the infection in the mouth?
Yeah,
Yeah,
we do.
we do.
Yeah.
Our trained clients do too, don't they?
Yeah.
Yeah. And how many times did he have to go back?
He
before
went
it
in
was
like 6
resolved?
times every 2 weeks.
So you're saying that 4 quads of SRP or scaling in the presence of gingival inflammation, one and done isn't done.
No. No, if they would have just done his
So
leg
weird.
one
That's
time,
how
it
we've
probably
treated
wouldn't
it
have done a
forever.
whole
Well, not us, but that's the typical protocol. And then forever perio maintenance. Here
Yeah.
we come, right?
Mhm.
So let's talk about the 6-month failure loop. What happens? Patients return 6 months later, the gums bleed in the same exact spots, or worse, the infection has progressed into periodontitis, which you all
Yep.
mentioned earlier.
Yep.
Mhm.
The cycle repeats itself for years, right? I know we did early in my career, okay? Gingivitis becomes normalized. That becomes like, oh, my gums bleed all the time. How many times have you heard patients?
Yeah.
My gums bleed all the time. New patients that we receive.
Yep.
My gums bleed all the time.
Yeah.
Isn't that normal?
I tell them, I said, well, if you had a hangnail, you're like, oh, don't worry, my hangnail, it just always bleeds. Like, and then they start to think, oh yeah, I would get that addressed. I would figure that out. I said, gums are not supposed to bleed, right? Like it's, you have to take it out of the mouth into the rest of the body.
So bleeding just becomes expected, right?
Yep, yeah.
And disease now becomes maintained.
And it becomes the norm.
That's not healthcare.
No.
As we've said many times, that's actually neglect.
Yeah.
And that's where lawsuits are formed.
Yeah.
Right? So periodontal disease is treated with minimal effort. That's my next topic. Periodontal disease is all too often treated the same way gingivitis is treated, right? In dentistry, minimum effort, hopium gain, or hopeful gain. And the dominant model looks like this: scaling and root planing on periodontal disease, follow-up every 90 days called periodontal maintenance, repeated root planing, sort of, repeated education. You need to brush and floss more, okay, right? And what I call repeated disappointment, because it's not curing the disease process. We're simply treating the symptoms all the time. So those 3-month visits are often nothing more than continued mechanical debridement with little to no effort aimed at eliminating the actual infection. Am I correct?
Yeah.
Yep, absolutely.
I'd actually like to add that most offices treating to insurance limitations will actually only scale half the mouth at a time. So that bacteria is definitely going to stay on one half of the mouth.
Thanks for reminding
and not
me.
touch this half for a week or two until you can get in to do the other half.
We need a bacteria coach.
That's right.
We need a coach for the bacteria. To coach them to stay
over here
on their side.
Because medical would totally just take half your wound and be like, we're going to clean half of it
this half.
today.
Insurance will only let us clean this half of the wound. So we'll see you back in a couple of days and we'll do the other half. And the bacteria will still be on that side. Don't worry.
Don't worry.
Wow.
Just wanted to add.
Funny when you put it like that,
rough.
but like that's really what people do with
That's very common.
Yeah. We're
Very
just
common.
we're just maintaining infection at that point.
Right?
You
Maintaining
just
a
went
low
right
grade
into
infection.
my next discovery for me when I was building this podcast, this YouTube broadcast. Now we see inconsistent protocols everywhere. We just saw one in one of the publications just yesterday. Tracy, my sweetheart and partner at My Practice, My Business, she actually read me the whole. I was busy doing some stuff, and she goes, "Oh, I'm going to read you a bedtime story." I'm like, "Honey, it's only noon." Did you hear her reading the story? Well, you were working while I wasn't.
Dang.
So she's like,
I wish I was there.
she's reading me the story of this whole big entourage of how we need to classify it 20 more times instead of just call it infection and treat it as an infection. The classification is so important. And nowhere in the article did it actually give any alternatives to traditional treatment of SRP and forever perio maintenance, or as one hygienist in our training called it, forever supervised neglect.
Yeah.
Like, that is a brilliant statement. So you look across the country, what do we see? Office protocols all over the map, because we see some people treating it with laser, some people treating it with this medicated mouth rinse, some people treating it with this one, some people rubbing clove on it, some people doing, all kinds of, I know. Yeah, and no consistency from office to office, and often no consistency within the same office. How many times have we trained offices and they can't even get the hygienists on the same page? Dare I say all three of you are on the same page?
Yeah, I think absolutely.
Yeah. We talk about it all the time. We collaborate.
We're nerds.
You collaborate.
We collaborate. We've got
We're
like
nerds. We're nerds about it.
Yeah. Well, we've got like the print off that literally step by step. So like we're all, you can't forget it. You know? Yeah. We've built a protocol.
Yeah.
My collaborative nerds. I'm gonna rededicate that to our text message portal. Yeah, I'm gonna do that. So often no consistency within the same office. Each hygienist is left to create their own version of periodontal therapy, which that's what we've seen too. And few of them have effective protocols for gingivitis. Very few. We've seen some, okay? And few are allowed to implement real infection control strategies. And that may sound harsh, but it's true. And our hygienist surveys that we've taken throughout the years, folks, have backed that up. That's why there's a lot of unhappy hygienists out there. Can I say that?
Absolutely.
Are you three happy?
Yes.
Very happy.
Now we are.
Yeah.
Good. There's nothing worse than unhappy hygienist.
That's right.
Right up there with an unhappy wife or husband, right? So why is oral infection treated so poorly? That's my next topic. I'm going to ask yourself, why does such fragmentation exist? This is what I started asking myself when I was creating this. And why are treatment modalities so inconsistent? And why is oral infection treated so differently than a medical infection, or how medical would treat it? And I think it's important for our audience to understand. I put myself through school as an EMT, and I had to do shifts through the ER. Back in the day, there weren't wound clinics, okay? The ERs oftentimes treated infection. And we would, as an ER tech, I would scrape the tissue with the best toothbrush ever. It was a wire toothbrush. Guess what we forgot? Did they numb your husband before they started treating it? What?
Hurt.
How can you do gingival debridement and really attack those deep-pocketed areas if the patient isn't numb?
Yeah.
Yeah.
And here's another $1 million question. I won't even go. I'm going to touch it. And do we charge for anesthetic?
Yeah.
Is it
code for
actually, are you performing a regional block or local anesthesia? Which one are you actually doing?
Both.
Yeah. I was going to say both.
Sometimes
Sometimes
if you
local, but-
infiltrate the gum tissue, that's a local anesthesia. If you do an IA, PSA,
That's regional.
It's a region.
MSA,
Yeah.
ASA,
Yeah.
those are regional.
Yeah.
Code for what you do.
Exactly.
Oh, but it's inclusive. No, it's not. Is it?
Not if there's a code for it as
And-
well.
Doesn't it fall under
code.
non-covered services? But so many dentists and hygienists are so afraid to charge for what they do because they've been brainwashed for umpteen years by third-party payers. It's free. Just like 170. Is it 170 or 171? Limited oral evaluation.
170.
170.
Yeah.
D0170. Oh, that's free too. Isn't there a cost of goods associated with your hourly wage, the direct operating cost per hour just to run your room?
Absolutely.
No, that's free too. Let's just give that away free.
And then they wonder why they're not profitable in
And
dentistry.
then they wonder why.
They're giving away things for free.
So, and here's a reminder that we can't ignore. A patient with bleeding on probing and probing depths of 4 millimeters or greater has an active infection, right?
Yeah.
And if there's radiographic bone destruction, they have active periodontal disease, or as we call it, Laura?
Yes, I know. I'm reclassifying it into periodontal infection because it's an infection. And when you call it a disease, I thought of this when you're saying we're just in that every 3 months maintaining a low-grade infection. What patient is going to fight and really up their home care if they feel like they can't do anything about it? When you call it a disease, they're like almost like,
Doesn't
okay,
matter
well, I
what
guess
you
this
do,
is what
you'll
it is.
have it
I
forever.
have it for forever.
It's a life
And
sentence.
so if you
They're
tell
not
them,
a little inflamed.
oh my
They're
gosh.
infected inflamed,
Yes.
right?
And so when
No,
you
we
start,
just have inflamed tissue. Very rarely
I've
do we have
stopped saying
inflamed
that.
tissue.
I'd be like, oh, your gums are bleeding a little bit. I'm like, nope, you have infection in here. There's a lot of blood. We got to...
And we can get rid of it.
Yeah.
And
Yeah.
what caused the
you-
inflammation?
Bacteria.
The bacteria. How often do we see gingival tissue that's just inflamed all by itself without no bacterial infection
Not
present?
often.
Not often.
Yeah.
Very rarely
Yeah.
in a systemic,
Yeah.
Yep.
Yeah.
somebody with a systemic disorder. That's the only time I've ever seen it.
But at the
And
same
that's-
time, their bacteria and plaque, even if it's minimal, it's contributing to it. So
Oh,
you just say,
absolutely.
like, you have to be better. Like, giving the patient ownership and holding them accountable, I think, is the
And
biggest thing.
the idea that those tissues are going to magically heal without medical style intervention, that is unrealistic. Can I just say it?
Mm-hmm.
It's not going to happen.
Yeah.
So I know my hygienist friends out there can relate, and I know that many of you want to treat these patients differently, but you're held back.
Mm-hmm.
And that's why you get frustrated, and I don't blame you. I would be so frustrated if I was trained in a hygiene program to treat infection. And of course, you're always told in those programs, once you have periodontal disease, you always have periodontal disease. Is that true or false?
False.
True.
It's true
That's
that
what
we're
we
taught that.
That's what we were taught.
Like, which
The
You
statement
see
is
the
false. It's true.
confusion
You're
that
taught it in
happens
school.
with the brainwashing? Okay,
No, we're
that's
just
what
very
you're taught
literal.
in
We gotta
school.
make
We are taught that in school.
Yeah.
But in reality, how many patients have you eliminated periodontal disease and
yeah.
moved back to
Tons.
6-month recare?
Yeah.
Tons.
So many.
How many did
Hundreds.
we actually document from 2017 to 2024? Over 350.
Over 300.
What percent? You don't remember.
It was a big number.
It was a big. And how many patients have reverted back and have been reinfected? What percentage?
Very small, and it's usually the smokers.
Smokers?
Or people that just like relapse on their health care.
Their
And
oral
they take
hygiene. They don't brush and
ownership of
floss,
it. Yeah, they're
right?
like, oh, I haven't been flossing
Right.
very good.
My favorite is the patient you came to me, Rob, you got to come check this patient out. Guess what he told me? When he goes on vacation, his toothbrush goes on vacation. I will never forget that.
Yeah.
And I go check him out. Oh my gosh, inflamed periodontal disease everywhere. I firsthand said it. Have you been on vacation for a half a year? What's going on here? It was really bad. So I'm going to ask a question. How gingivitis should be treated? So let me suggest what gingivitis treatment should look like. And it's actually what we talked about. Scaling in the presence of gingival inflammation. That's the first thing you take off on, right? Antibiotic placement in the sulcus into the infected areas. And that's up to you. If it's a small infection, sometimes the scaling will work. But who do I leave that decision up to?
Us, the people treating it, yeah.
The people doing the hard work,
Us
right?
in the trenches.
What about a medicated mouth rinse? We talked about chlorhexidine. On gingivitis patients, oftentimes I see the three of you will put them on OraCare maintenance, right?
Yeah.
It's a great rinse.
Yeah.
And that really helps a ton, correct?
Yeah,
Yeah.
well, recently, they came out with the chlorhexidine not being great, especially because it's not meant for a long-term use.
Right,
So
exactly.
depending on the patient, if you need them to be using it longer, the chlorhexidine is not appropriate.
No.
it
So
just
gingivitis, boom. We
Yeah.
hit it with chlorhexidine
Right.
for a couple of weeks,
Yep.
knock down everything.
Clear it up.
And then we want to balance the pH. We want to balance the good bacteria with the bad bacteria.
Yep.
And Carry-Free has done a great job with that. I might as well just say it now. What is our go-to mouth rinse for periodontal disease?
Or care.
And we've used everything for years, haven't we?
Yep.
Yeah.
And what is the rinse that we see the best results with?
OraCare.
Yeah.
That's your wheelhouse, not mine. I trust what you're seeing. All I know is when I go to see the patient after you've eradicated the infection, we take a second pathology test, and that pathology test, 9 times out of 10, comes back healthy as can be. And what happens if they're healthy in the mouth and it comes back unhealthy? What happens? They just have bad bacteria.
Yeah. They've got to be more
they've
vigilant
got
with home care.
more diligent in home care. We keep a closer eye on them. Sometimes we put those patients on every 90 days,
Yeah.
don't we?
Yep.
Yeah, for sure.
But that is a decision that was made with medical testing and science behind it, not some arbitrary number that the insurance companies pay for.
Absolutely.
And it's patient-centered, patient-driven. Healthcare is not one size fits all.
Laura, you just said it. It's patient-centered. Oh my gosh, that's a phrase that we don't use enough.
Yeah.
So we do spit tests on gingivitis sometimes, significant oral hygiene instruction. I hear you in there screaming at them. No, you're not screaming. I hear the most powerful instruction going on to our patients as I'm listening to you. You're using EDGE. You explain, demonstrate, guide, and enable. You explain to them how they should floss. You show them how they should floss. And then what do? They have to show you how to floss. Brushing the same way. And then follow-up 2 weeks later. So, wow, that's shocking. Every single one of those treatments that I just described there has a CDT code. We're not even talking about any created codes with value-added service there, are we?
No.
What a concept.
Yeah.
So the insurance myth. I know what you're thinking, but insurance doesn't pay for that, Rob. So let me ask you something. If a dental plan doesn't pay for needed therapy, does that mean we don't do it?
No.
No. Does that mean the patient doesn't deserve it?
No.
Absolutely not.
And in our practice, which is predominantly PPO driven, right?
Yeah.
Okay. Patients pay for this every single day without complaint, don't they?
Yeah.
Can I ask you why?
I think it's because we do such a good job at really hammering down, this is why you need it. We educate so well. And I think that really hits home for the patients, and they understand the oral systemic link. And so they're cooperative.
But you're saying something that most hygienists aren't able to do. And you just said it with one word, the E word.
Education.
You educate them.
Yeah.
Yeah.
You have time to educate them. You have time to care for them. We're not double scheduled, right? Double and triple booked. We're not killing all of you like so many offices do because they think that's how they can increase profit margins in a PPO-driven world, let alone fee-for-service. In fact, it's shocking how many practices think they're profitable and their fee-for-service fees are just barely break even, right? Well, it's because the infection is explained, which is what you said, because the outcomes are real, which is what you three do all day, and because the results speak for themselves.
Absolutely.
And you see it. That's your wheelhouse. You just report to me all the time or bring me in if you see something you don't like, right?
Yeah.
I love it.
Yeah.
So I just want everybody to know that my hygienists are eliminating gingivitis within 2 weeks over 98% of the time. Is that a fair assumption? Because that's what our statistics show in our software.
Yeah, totally.
By treating infection like medical would. Do I need to say that again?
Yeah.
By treating infection like medical would.
Yeah.
Thank you. When did dentistry become so brainwashed by perceived insurance limitations? I've asked that question millions of times. The insurance companies, our own associations have done that to us, consultants, and we have broken that mold at My Practice, My Business, haven't we? Yeah. Nichelle's been with me for many years, but Laura, Courtney, when you guys came on board and went through our training, were you a little on the shock side with what you saw?
Honestly, it made sense, but it was so against the grain of everything we were taught and just how dentistry is in general that that was the mind-blowing part. It was like, this all makes so much sense. Why isn't everybody, it was just like, wow, we're behind.
Common sense isn't so common, is it?
Dentistry is behind.
Yeah.
Behind medical.
Step up your game, for these patients and for your clinicians.
So let's talk about periodontal disease then, okay? You three see success stories all the time. So if you think our gingival therapy patients are amazing, you should see our periodontal therapy patients. We treat periodontal infection like medical treats infection, like we've talked about. And because of that, we eliminate periodontal disease in over 95% of our treated patients. And those patients are put back on 6-month recare. In fact, those patients are so healthy that when other offices come through our training and they're shown the healthy side of the patient, they're like, that patient doesn't have periodontal disease, don't they?
They don't have periodontal disease.
They never had periodontal disease.
Okay.
No. So it's like, it's weird, right?
Yeah.
And if those patients happen to go somewhere else, they're never diagnosed with periodontal disease. They're never placed back on 90-day perio maintenance, ever. When they move out of town and they leave our practice.
Yeah, their
Isn't that
new
crazy?
office has no idea.
Yeah.
And the majority of them stay there.
Yeah.
Isn't that cool? That's what we accomplish. So we talked about smokers and non-compliance are the ones that are the ones that fall back, but very few. And how many people have we been able to get them to stop smoking? How cool is that? Yeah. The next topic I want to talk about is supervised neglect. All right, so that's the every 90-day. Offices that rely on traditional scaling and root planing followed by endless periodontal maintenance rarely clear the infection. What do I mean? We've had a few of our patients back in the day go to a periodontist. We still see those patients. When they come in, I probe them, and they still have bleeding pockets. Why is that?
They're not treating it the way they should be. That infection, they're not clearing it up. They're literally just doing this cycle.
Doing the same thing that a regular office would do. And it's so crazy to think I graduated in 2008 and we're still treating periodontal disease the same way. Right. And medical is always changing and always trying to do things better. I'm like, why are we just good enough?
In the ADA News, a general dentist wrote an editorial letter and he said, can we stop reclassifying periodontal disease for the umpteenth time? Can we just all come up with an agreed solution to eradicate the disease? It should be able to be eradicated, he stated. It's an infection. Once you have periodontal disease, you'll always have the effects of periodontal disease.
The bone loss.
The bone loss, exactly.
Yeah.
But you'll not
But you don't
always,
have to have that infection.
You don't have the bleeding.
which is the
the
cause.
infection.
Yeah.
The cause of periodontal disease, with everything I've ever read and experienced, is infection. Crazy. Okay, so
Just makes sense.
my next area is the hygienist frustration is real, isn't it?
Oh,
Okay.
yes.
Yeah.
The burnout.
The burnout.
Yeah.
You wonder why our profession has such a high burnout rate for hygiene. It's exactly everything we've been talking about.
Because we double and triple book you because we think that's how to be profitable.
But
in
really,
the
we're not
practice.
treating the right way.
Exactly.
we were
and
treating
if
the
you
right
treat it the
way,
right way, you
We
can be
wouldn't
profitable,
need-
right?
Yeah, we wouldn't need to be double, triple booked.
Yeah.
So you're held back.
Duh.
You're held back by the doc.
Our time, like that is a huge thinking of the 15 minutes.
Yeah.
Like you just get in this like burned out, beat down cycle of like, well, I guess this is how it has to be
This
done.
is the
and
best
you
I can
can't-
do with the
yes,
time I have.
with the time I have, and patients aren't learning, so they're not getting better. And you're like, why am I doing this?
Yeah.
And
All
here-
I'm doing is seeing.
It's hard as like
unhealthy
a medical
patients.
professional to realize like I'm not doing anything for these people. I'm not fixing them.
Yeah.
And it's so fun to be like that person no longer has infection and like we did that together.
Yes, they're excited.
They're
They
part
love
of the
it.
team, aren't they?
Yeah.
Yes.
Okay. Michelle, remember hygienist? Rob, I want to suggest something. Instead of using these piezo scalers,
You always have to bring this up.
Yes. Thank you, Nichelle.
I know.
You're welcome.
I cannot work here with a PhD.
Dentsply makes this sonic scaler
Such an
that will
old
make me a better
thing.
hygienist than I already am. I know you think I'm perfect. I will be more
I
perfect.
didn't say that.
Okay. It's like, and then I looked at you. I'm like, great. How much is it?
You're like, $5,000.
Just $5,000.
This was like a long time ago.
And then it's
Before COVID.
I know, right?
But if we buy it and we could get this whole additional package deal, and it ended up being like $8,000.
Probably.
And I'm like going, $8,000. That is so much more money than the
But
piezo.
you have to have the right tools
And
in
that's-
order to treat periodontal
that's
disease.
denied tools and medication.
Yes.
Yeah.
And that's the problem.
Yep.
And have I not always, ladies, when you
Yeah.
come to me, we need new scalers, we need new tips, we need to whatever. Do you even hardly pass it by me?
No.
If you have scalers that are dead, you just order them.
Yeah.
If you have Cavitron tips that are overused, you just order them,
Right.
right?
Yeah.
Do I ever say no?
No.
Oh, well, one of the reasons I never say no is because we're profitable. We're
Yeah.
Yeah,
profitable.
I was thinking this like
Our-
there's money.
Our
to buy
profits are
them.
profitable. We haven't even touched the regular healthy patient and all the value add that we can bring to them. We won't even get into that here because that's a whole nother topic. But we're profitable in the hygiene department. And it's not because we're piling on 9 million sealants on every tooth, and it's not because we're doing, we're forcing more treatment or selling treatment. No, we're providing care that the patients actually need. And that's the difference. And that's when the patient says yes. That's when the patient says, I want that product before we scale and polish. I want whatever it might be. But that's the big difference. And medications. And it's fun, Laura. We won't get into that particular product because we don't have a track record with it yet.
Yep.
But there's a product that all three of you are now trying
Yep,
out
yep.
and you're using, and the jury's out. And I can't wait to report on it if it's fantastic.
Yeah.
And then you're limited by schedules. How many times we hear the hygienist, if I have to treat a patient, for multiple visits every 6 weeks until the infection is cleared up, I don't have room in my schedule. If we had $1.
Yeah.
And then they don't want to think outside the box.
Yeah.
No, they're like scared. I don't know. Cause when I was like Courtney, when I heard this, I was like, yes, this is what I've been waiting for. And so many of them are just scared.
But Laura,
Yeah.
they're not paid like you three. They're not paid like an associate.
Yeah.
I pay you ladies a base plus commission, 18% of what you produce.
I actually just spoke with a newer hygienist out of school the other day at a temp office, and she's been slaving just trying to get this office like up to, speed. And I mean, she's doing scalings maybe 2 a day,
Yeah.
big cases, like heavy cases.
Yeah.
And And I told her that I got paid off a commission here, and she's like, that's not scary, because like there's like this scary, I don't know, stigma behind
What
it
if
or
I don't
something. And
make
I
money?
said, honey, I was like, you're working your butt off. I was like, you should be getting paid for what you're doing. I was like, with your
just like an
schedule right
associate
now,
does.
you would make well above what you should.
I'm a producer. Aren't you three producers in
Exactly.
the practice?
Yeah.
We have wonderful support team members in the front and the back who help us do our jobs. We couldn't do them without them.
Exactly.
We work as a team.
But taking ownership.
Taking ownership of what
It's
they
huge.
do. Wow. So, and then conditioned to believe insurance dictates care. That's the other one.
Right.
So at the same time, many hygienists don't realize how much more they are capable of.
Absolutely.
She's realizing how much more she's capable of, but she's not being paid accordingly to the capacity, right?
Mm-hmm.
Yeah. So there's a better way, isn't there?
Mm-hmm.
They've just never been shown a better way.
Dentistry doesn't like change.
No.
It's really interesting because we just like to do it the same way over and over.
Right.
But that's the definition of insanity because we're not getting different results.
Yeah.
We're just like beating our heads against the wall. Maybe this time this patient will care enough to floss. And I'm like, but if you teach them why, then they're like, oh, you're not just nagging me?
Yeah.
I'm like, no, I want to
I
help
actually
you.
care.
Yeah.
Because I actually declared my love for a patient the other day. So it's just because I love you. And I was like, in a not weird way. But we care.
I'm glad that you actually explain
who
and
this patient
educate
was.
them, not in a weird way.
Right. Like, but we care about their overall health.
When you are caring for, especially our perio patients and the gingivitis patients to a degree, but not as much. I see how committed you are to the perio patients.
You become friends with them.
That was a gingivitis patient.
You're invested.
Yeah.
You're invested in your time. You're invested financially. You're invested in their care. You're invested in your training. You're invested in a positive outcome for them. And I see it. And I applaud you three for that. And every office that we train that implements our protocols on periodontal therapy and gingival therapy, they see the same thing.
Yeah.
We get all these people calling back and calling in. My favorite is a hygienist calling back. We did the protocol.
Yeah.
All I can say is I'm floored.
Yeah.
I'm not sure what floored means. I'm still, maybe I need a dictionary, or something. But that was the cutest statement I ever heard. I'm floored. And I said, so what are you floored about? And she goes, it works. We have been moving patients back to 6-month recare. Now we're at a 2.5-year mark, and they have not gone back into periodontal disease at all, and they're not even close to even looking like they are. And that's the fun stuff. So how do we break the cycle? How do we charge for this? Well, stopping the downplaying of dental infection. That's number one. Yeah. We have downplayed dental infection for too long. Agreed?
Mm-hmm. Yeah, absolutely.
Treating gingival infection aggressively, like your husband was treated with the infection on the back of his leg. That's how medical treats it, right? Mm-hmm. That's how my son treated it when he worked for IHC.
I love how the dermatologist was like, just put a Band-Aid on it. That shows what we in dentistry kind of do. We're like low effort, like just start brushing and flossing. It'll be fine. We put on these little Band-Aids, but you go to the wound clinic that's specialized in this and they're like, whoa, no.
Yeah, we can treat this and you should get rid of this before
you. Yes, and so we all should be like that rather than just putting on the Band-Aid.
And we can still take dental insurance, but we reject insurance-driven care.
Yeah.
It is so easy to be paid for all 4 quads of SRP. You don't have to do 2 and then do 2. That came out during COVID, and the insurance companies, you got to hand it to them. That was a brilliant business decision on their part because they know that 17 to 20% of the patients will not come back for the other 2 quads, and they make more money.
Yeah.
Hey, I loved it. Okay. Anyway, don't throw things at me. Educating patients on the seriousness of the oral infection, just like you mentioned, Court. Education is everything.
Taking the time.
And
having the time. Thanks to you.
And sending them home with documents that actually educate them.
Right.
And show the why you're going to do the certain protocols that you're doing.
Yeah.
And there's only one system, My Dental Docs. It actually does it. And only our trained clients get that system. Sorry, folks, but that is the most powerful. Would you agree with me that's the most powerful educational system that we have in dentistry?
Yeah.
Yeah, understanding the systemic consequences of infectious disease in the mouth. Isn't that important? Yeah. And only then do dentists and hygienists work as a true team, not a hierarchy. Do we work as a hierarchy?
No.
Well, I kind of think you guys override me all the time, but no, we work as a team, don't we? I love it when you come to me and we collaborate. Who said collaborate earlier?
I did.
It's my favorite because I wish dentists and dental hygienists would. It's not a competition.
No.
We're not
It's
better
not a
than dentists.
hierarchy.
Dentists aren't better than us. It's a collaboration. We need to work together.
But the thing is, you have your wheelhouse. We have our wheelhouse.
Exactly.
So
So
let's
why
do
can't
what
we
we
work
do.
together for the good of the patient and their care? Mind blowing.
And
What?
when that thought leadership exists,
Right.
autonomy is not needed.
Yeah.
Because I give you guys autonomy
Right.
Mm-hmm.
Yeah.
all the time. And so I'm like, and isn't there so much work to be done? Why do you want expanded duties? Look at how hard you're all working. And I'm gonna, I need to say it right now. Hygienists prolong and save lives. I've said that for umpteen years. Things that I do every day does not prolong and save lives. Makes people happier and get them out of pain and increases self-esteem. But look at how many people in the state of Utah, that just the ones we know about, have died from periodontal infection.
Yeah.
And that's what's really sad.
Yeah.
Your dad has seen it. We've seen it in other areas of the state. And if we eliminate that infection, we prolong their lives
Absolutely.
and we save their lives. And until, in my opinion, until hygienists are viewed like that by the dentists that they work with, there's always going to be a little rift. And I'm grateful. I'm grateful for the work that you do on all of our patients, and I'm grateful that you work with me as a team. I do have a lot of knowledge. I don't do what you do every day, so my skill set is rusty to non-existent, right? And if I had to, it'd be a little messy at first, but
it's always messy. Don't worry, Ralph.
That's why you get them numb. It's fine.
But that's why we have front office team members. That's why we have back office team members.
Yeah.
And working as a team, it's so much better, and collaborating with one another. So I want everybody that's watched this, if this episode's resonated at all with you, especially if we've made you uncomfortable, thank you. I'm glad we have.
Yes.
And because that's actually a good thing. Change never happens unless we're honest with ourselves and we're put in an uncomfortable position to actually want to make change. And that's what I love most. Any of you three wonderful ladies have anything to add to, take from? It's your turn right now.
I feel like we summed this up very well, and I feel good about it.
When you were saying my dad has seen it, I just got caught up in thoughts about it. My dad knew a lady who died from periodontal disease, died from a heart attack caused by periodontal disease. And when you stop to actually think about these people and their health, and the fact that you can or can't or may not do something, or you can do something to help them, I don't know. I think that's really powerful. It's cool that we have the ability and the education to do that.
Absolutely.
Good point.
Yeah. I'm just building on Nichelle. I saw a statement that said periodontal disease in your 30s means heart disease in your 50s. And so that right there, I'm like, that shortens your lifespan.
Yeah.
That absolutely does. Periodontal disease may not kill you tomorrow, but the effects of it are going to catch up to you. And I feel like us as hygienists aren't really taught that, and we almost don't believe that. We're taught with systemic diseases, but it's not put in such a simple way of this will impact them later. This will, if I do not stop this train now, it's just going to keep chugging along until they have irreversible problems. And so I try and think of every patient, like you said, what would I want to do if this was my mom, that I'm like, no, we got to get this out of here. We got to get this infection gone. And I teach my patients that, and then they understand. And I think we're giving them tools. We're giving these patients tools of how to care for their mouths. And I let them feel, I'm like, I've known how to take care of my teeth properly now longer than I have not known.
Yeah.
I learned in assisting school when I was 18. So a lot of us forget that we just know, and our patients don't.
Yeah.
And we just need to take that time And we need to believe that we are prolonging and saving their lives, because that's exactly, and that'll change our whole thought process of I'm going to diagnose them or I'm not, but that's a lot of power, but it's cool to be able to make that change.
Yeah, absolutely.
Yeah.
I don't have anything more to add to that. I want to thank everybody that's been on our YouTube channel, that's been watching this presentation. I want to thank everybody that's all of our subscribers on our podcast show. If you like what you hear, we'd love to have a review. Please share our YouTube channel and our podcast channel with your friends in dentistry and your especially docs that are listening. Share this episode with your hygienists. And by all means, if this has resonated with you, you should check out our training at My Practice, My Business. Go to our website, mypracticemybusiness.com. Look at the amazing training that we do give. And one of the biggest segments in our team training is on periodontal disease and gingivitis. We'd love to see you at one of our trainings. We are one of the very few, if not the only company that guarantees that training. If you don't make income, we don't get paid. I don't know of a consultant that does that.
Yeah.
But that's dental consulting the way it should be.
Yeah.
Again, thanks for listening. We hope you all have a great week and hope this has been inspiring and hope this has caused you to think about treating infection in the mouth in a different way. Till then, have a great day.
Thank you for being with us today. Since 2006, My Practice, My Business has been teaching dentists and their teams business skills, dental insurance contractual protocols, and state laws governing how to profitably bill patients fairly for the need-based services they provide. What's more, we guarantee our training, unlike other dental consulting companies in the industry. Simply stated, if you don't increase your net revenue, we don't get paid. We call it dental consulting the way it should be. We believe there has never been a more important time than now for dentists to experience and implement our key methods, knowledge, and business training within their dental practices. To learn more about our guaranteed, no-risk clinical business of dentistry training that is changing dental practices for the better, just go to our website, mypracticemybusiness.com, and surf our pages for additional information about our company and the services we provide. When you're ready, give us a call and get scheduled for the most profitable dental business training that you will ever experience. If you enjoyed our podcast, please leave us a 5-star review. If you have any questions, please don't hesitate to call us. Thank you again and have a fantastic day.